My name is Leonardo Tjahjono. I am an assistant professor at George Washington University, Department of Dermatology. I'm also the director of inpatient dermatology. Life has been exciting for me, seeing the complex cases, the worst hospital cases, because we're the safety net hospitals for the DC, Maryland, Virginia area. But yeah, today we're going to be talking about general pustular psoriasis and Spesolimab. I think the specific thing that I want to mention is that how well it really works, despite the GPP disease duration before the treatment, and also to describe the difference between inefficacy between the every 12-week and the 4-week dosing. So, in my experience, and based on the clinical trial data, the fortunate thing is no matter how long you've had the general pustular psoriasis, they work relatively well for any type of duration, short term and long term. I am unique as a dermatologist could be because when patients are doing well, no matter what inflammatory condition, I try to taper a little bit different from the on-label medication. So let's say currently Spesolimab subcutaneous is indicated for every 4 weeks. I do myself try to, once they're under great control, try to extend it to every 8 weeks if I can, depending on the flare. Now, for this specific medication, Spesolimab, which is an IL-36 inhibitor, in their phase 2b study, the Efficacy, they did a dose ranging studies. That means the placebo was compared versus the low dose, which is 300 milligram loading and 150 milligram every 4 weeks. And then the medium dosing, which is 600 milligram loading and then every 12 weeks, which is what we're going to be talking about and what we're going to be comparing to. And then the dose that is finally approved by the FDA, which is classified as the high dose, which is the 600 milligram loading and maintenance every 300 milligram every 4 weeks. Now, during the study, there is no difference between the placebo and the medium dose, which is the 12 weeks that I'm talking about right now. The dose is not approved, and patients do develop flares before their second dosing, and then there's no statistical significance with the placebo. Now, comparing the placebo to the actual FDA-approved dosing, which is the high dose, 300 milligram every 4 weeks, that's when we start seeing that noticeable improvement, and patients remain flare-free throughout the whole duration of the study. Now it's really hard when you probably can infer that the 12 weeks is not as effective as the 4 weeks numerically, but when your study is not designed to compare head to head, you can't really say superiority specifically. But as we can probably kind of infer that it's definitely less effective. And in my experience, my patients do flare between the 8 weeks and 12 weeks when I try to maintain them. There's one small caveat. There's 2 or 3 case reports in patients that had severe flaring in the hospital with GPP, and they get that 900 milligram IV dosing. They only needed that one dose, and the clearance is maintained for 6 months. There are a few cases, but again, you can't compare apple to apple because that one is an IV dosing, and it's not it's more like the very severe flare that got them in the inpatient hospital.